Greetings from Cape Town, everybody. I'd like to start out by saying a big thank you to the organizing committee for inviting me to contribute to this very important meeting. My name is Mpiko Ntsekhe, cardiologist based at the University of Cape Town and Groote Hospital. I'll be speaking to you about HIV as a risk factor for cardiovascular disease with a focus specifically on heart failure. Now, HIV increases the risk of developing 6 forms of cardiovascular disease. It doubles the risk of atherosclerotic coronary artery disease, peripheral vascular disease, and stroke compared to HIV uninfected controls. Although rare at 1 in 200 patients, HIV-associated pulmonary hypertension is up to 1,000 times more common than it is in the general population in people with HIV. Now, in sub-Saharan Africa, patients with HIV are at increased risk of large vessel vasculopathy that presents as aneurysmal dilatation of the aorta and related branches. And then patients with HIV remain significantly increased risk of developing TB pericarditis in TB endemic areas. And interestingly, the risk of post-tuberculous constricted pericarditis is significantly reduced in those who are HIV. Most recently, following the publication of this study of sudden cardiac death in patients with HIV, we now know that HIV increases the risk of sudden cardiac death. The incidence of sudden cardiac death in people living with HIV compared to matched controls is approximately double, with an incidence of 25 per 100,000 patient years in those who are HIV infected versus 13.3 in those who are not. Investigators here also demonstrated high rates of myocardial fibrosis as the arrhythmogenic substrate in those developing sudden cardiac death. Now, the burden and phenotype of cardiovascular disease in people living with HIV in the ART era, that's antiretrovirals, differs significantly by geography. So what you see on your map there is that in North America and South America, atherosclerotic cardiovascular disease predominates. However, as people live longer with their coronary artery disease and other traditional cardiovascular risk factors, it's anticipated that the burden of heart failure is growing and may become dominant. In sub-Saharan Africa, where the vast majority of people with HIV live, heart failure predominates well over atherosclerotic cardiovascular disease. Now, there's been an evolution of the heart failure phenotype in people living with HIV as better and better antiretrovirals have become part of the treatment regimen. In the pre-antiretroviral era, patients developed heart failure with reduced ejection fraction. It was driven by high viral loads, infectious myocarditis, and toxic drugs. In the post-ART era, patients, the phenotype has changed to a heart failure with preserved ejection fraction. And although we're not 100% sure, this seems to be driven by traditional risk factors and persistent immune activation. Now, since 2011, there have been 4 large observational studies designed to determine the risk of heart failure in people living with HIV on ART. All have been conducted in North America. 2 were prospective cohorts, and 2 were analyses of large healthcare system databases. Essentially, the message from all 4 is about the same. After adjustment for demographics and cardiovascular risk factors, HIV doubles the risk of heart failure. Now, amongst those on ART who are well controlled, the risk is greatest for heart failure with preserved ejection fraction. And although HFpEF is much more common, the risk of heart failure with reduced ejection fractions remains significant at well over 50%. Again, high viral load, low CD4 count at the onset of ART remain important determinants of risk for both HFpEF and HFrEF. The potential causes of impaired cardiac function in those with HIV-associated HFpEF have also been under investigation. Amongst those without coronary artery disease, 2 potential causes stand out, and they include myocardial steatosis and myocardial fibrosis. If we look at the issue of myocardial steatosis, It's important to realize that the prevalence of non-alcoholic fatty liver disease in patients with HIV on ART has been estimated to be between 30 and 60%. The reasons for this are multifactorial. They include hepatitis C, antiretroviral drugs themselves, and obesity. And importantly, NAFLD, as it is called, is associated with increased risk of HFpEF. Now, using MR spectroscopy, 2 studies suggest that people living with HIV on ART have significantly more myocardial lipid content and steatosis than matched controls. No correlation has been found with markers of abnormal glucose or lipid metabolism, HIV disease, or ART. Research in this field is ongoing to elucidate the exact determinants and mechanism of myocardial steatosis. With regard to myocardial fibrosis, there's been 3 recently published CMR studies which suggest increased myocardial inflammation and fibrosis relative to age and gender matched controls in patients without HIV. All of these studies were conducted again in the US and the UK. Now, in collaboration with colleagues from the University of Minnesota, we have established here in Cape Town have established a research program to investigate preclinical structural and functional abnormalities in asymptomatic patients on ART by means of cardiac MRI. Now, it's important to contextualize this. People living on ART in South and Sub-Saharan Africa have a high burden of hypertension and obesity, commence ART at a relatively low CD4 count, and have high rates of opportunistic infections such as TB prior to commencing ART. So the study hypothesis basically is that myocardial inflammation and fibrosis, as determined by CMR in asymptomatic people with HIV, will be high compared to controls without HIV, as driven by immune activation and monocyte-induced myocardial injury, and correlates with biomarkers of cardiac stress and injury. So we have recently published preliminary findings from this study looking at the first 132 patients and 98 controls, and we found significantly greater degree of fibrosis by extracellular volume. And interestingly, the prevalence of late gadolinium enhancement was also high in patients with HIV, but also unexpectedly high in our controls. There was no correlation with BNP, troponin, which were not elevated in both groups. Immunological analysis of the work is pending. Furthermore, we found no evidence of abnormal systolic or diastolic function in either group, and the frequency of left ventricular hypertrophy was low in both groups, with no differences in LV mass index. So excitingly, on the basis of these preliminary findings, we've recently got NHBRLI funding to conduct more research in this area between 20 and 25. We're planning a 1,200 patient study of asymptomatic individuals. This will be powered to determine the prevalence of asymptomatic structural and functional myocardial abnormalities and precursors of heart failure, and explore the prevalence and patterns of both fibrosis and steatosis. Additionally, we'll be able to investigate the role of inflammation, immune activation, activated monocytes involved in this myocardial injury and fibrosis. And we will also be able to explore the impact of traditional cardiovascular risk factors such as hypertension, obesity, and dysglycemia, and the role of antiretroviral therapy in heart failure. With that, I'd like to thank you for your attention.